Yeah, good afternoon everyone, and welcome to this instruction course. This instruction course is going to be talking about simplifying the complex, that is phacoemulsification in complicated cases. We all do normal phacoemulsification, but when we have tough situations, we have to work with it
right?
in a tougher in situations where we get the best results. Dr. Gaurav Luthra has not been able to join us. He has not come to the conference, so we might be skipping his talk on pupil and iris issues. But to start with, I have with me Dr. Raghav Malik. He is a consultant at Center for Sight Group of Eye Hospitals and extensive work in phacoemulsification and refractive surgery. And the first thing that all of us fear is a hard cataract. So he is going to talk about managing the hard nut. And over to you, Dr. Raghav Malik. Please feel free to ask questions in between, and later at the end we can also have discussion. Over to Dr. Raghav.
Thank you, sir, for this wonderful opportunity. Today I'll be speaking about how to manage the hard nut, that is the hard cataracts. You can have, or you can, what you also call the mature cataracts. We have two types of mature cataracts. One is the one that is really hard, that is the grade 4 and the grade 5 nuclei. And also we have the white nuclei, that is the intermittent type. So I'll be speaking on both of them, how we should manage them and how we should proceed. So a hard cataract is always a challenge. It is very hard. We have to know how to proceed. There are certain pre-operative evaluations which we have to consider. There are certain intra-operative challenges, and of course there are some post-operative challenges. So the Swedish capsule rupture study did set out its own set of complications that are associated during and after a hard cataract surgery. So the pre-operative considerations include, but are not limited to, seeing the pupillary dilation. Of course, seeing a dilation is very important. Having a well-dilated pupil is very important so that we can assess the density of the cataract and also see the zonules, whether the zonules are intact or not. Having deficient zonules and a hard cataract is a very bad combination. The corneal endothelium, doing a specular microscopy prior to the surgery to see how well and how healthy the endothelium is also very important. Zonal integrity, like I said, having a hard cataract and deficient zonules can lead to complications. And of course the morphology of the cataract, whether it's a hard cataract or it's an intermittent cataract, we have to proceed accordingly. And the posterior segment evaluation, because oftentimes we do have case where we have a hard cataract and we cannot see the fundus, and if we do a surgery and of course there is, let's say, a dense ARMD or a wet ARMD and patient does not have a good vision after surgery, we can have certain legal issues also. So doing a B scan for the fundus is very, very important. So the intraoperative challenges in a hard cataract have its own set. So first, of course, because of density of the cataract, we cannot assess the fundus easily. So we do have to do some investigations like a B scan or an A scan just to see the integrity of the retina and whether there are any opacities in the vitreous cavity. Secondly, doing a rhexis is also very difficult. Having an intermittent cataract, doing a rhexis is not the most easy job. You can have a run out, and once you have a run out or an Argentinian flag sign, it has its own set of complications. Next, the depth is also reduced. Because once there is a dense cataract, you have intumescence, our AC depth goes down and you have less space to manipulate inside the anterior chamber. So we need to have some thick or a cohesive or a viscoelastic so that we can maintain some space, and also do a dispersive viscoelastic, do a soft shell technique so that we can maintain space in the AC as well as protect the endothelium. The corticocapsular adhesion, there could be, which will lead to difficult hydrodissection and rotation, and if we try to rotate, we can have disturbance of the zonules. And lastly, nuclear changes. When we have a dense cataract, breaking the posterior or the backbone of the hard nucleus is very, very difficult. So we have to see that the nucleus has been broken down well up to the backbone. Now how do we need to know what is the anatomy of the nucleus, starting from the inner depth of the nucleus up to the epinucleus and the cortical layers. Of course, once we have a dense nucleus, a mature cataract, the epinucleus tends to go into the nucleus and we don't have an epinuclear cushion. While doing the cataract surgery, doing phacoemulsification, you might not have that epinuclear cushion to save your posterior capsule. So we should know how to go about. There are many ways to go about breaking the nucleus: trenching, splitting and chopping. Our technique is mostly the direct chop. So as you see in this photo, also this image, you can see that having a breaking the backbone, that is from the upper epinucleus to the lower epinucleus, is very important, so that the entire, you have two entire heminuclei which you can break. Having a superficial crack will not help. If you do have a superficial crack, you will not be able to break the nucleus down and you will not be able to chop. You will only keep wasting time by rotating the nucleus, and in effect you can have a zonal dehiscence. So movement of the nucleus and your wrist is very important. Chop properly. Go take your phaco probe up to at least 2/3 of the depth of the nucleus and use your chopper to break it down. Intraoperative considerations, there are various techniques to chop the nucleus. My preferred technique is a primary chop or a direct chop. This is one case. If you can see, this is a grade 3 to 4 cataract. So if you see, this patient has a very tenacious capsule. Dyeing using tricot is very blue is very important, so that you can stain the capsule and you can see. Now I am trying to do a rhexis and I want to have at least a 5.5 millimeter rhexis or maybe more. Why? Because I know that the diameter of this nucleus is very and something goes wrong, I can always prolapse the nucleus into the anterior chamber. So I'm trying to have my rhexis at least 5.5 millimeters, and if I'm not completing my rhexis, I will take my rhexis out and I will enlarge it. So now I have a decently sized rhexis and I go ahead do my hydrodissection. A very gentle hydro. If I do more hydro, I will increase the intracapsular pressure and cause a PCR. Just see that yes, we have to rotate the nucleus very well. Now this is my first attempt at chopping. My first attempt, I go up to 2/3 of the depth of the nucleus. I try to chop, but I will be unable to do so. Why? Because it is a very thick and leathery carotid in a diabetic patient. So my first attempt, not very well, but I have made some crack. I go into that same groove and I go much deeper, 2/3 of the depth, and now you see I can easily crack. So now I will rotate and I will complete that chop starting from the anterior to the posterior epinucleus. Once I have that, and I have rotated 180 degrees, and now I chop, and that's the complete break. Once you have that, that is the tough part that is done. Then you rotate and I can have my quadrants. And once I have my quadrants, doing phacoemulsification is quite easy after that. Yes, so this is my 4 quadrants. Then I take it up. Of course, after every quadrant, I'm going in and I'm putting a dispersive viscoelastic so that I can protect my endothelium, because we also have to keep a track of the ultrasonic power we are using. So there can be modifications to the primary chop. Of course, if it's a very hard cataract, we might want to go and do a mini trench and then use that trench to chop the nucleus. So if you see in this case, it's a grade 5 cataract, 4 to 5. We're doing a trench, and in that trench, go deep, and then we are using a chopper to break. If you see in this case also, we are trying to chop so that the posterior fibers are also broken, because if that is not broken, then the chop is of no use. So breaking the posterior fibers till you see a very good glow, that is very important. And once you do that, rotate by 180 degrees and complete your chop. And then once the chop is completed, make your quadrants, and having the quadrants, use the first quadrant, take it up. Once that first quadrant is gone, you will have more space, and you can use that space to manipulate your nucleus and chop further. That's it. And once that is done, then it is quite easy. But doing the primary chop, that is the most important step. And of course, always remember to keep using dispersive viscoelastic. This is of course using, sorry. So now this is, we are using a grade 5 cataract and using femto. So you can see the most important step, that is in a hard cataract, once we have the rhexis, you can be rest assured that even if you have a complication, you always have the support of the sulcus. Once you have the support of the sulcus, you or your retina person can always go in and put a lens in the sulcus. But yes, so that is one of the major advantages of femto in your hard cataracts. And once the rhexis is done, then you can go ahead and you can chop. Of course, in a very hard cataract, the femtosecond, we might have to increase the energy. And once we increase the energy, then we can have a chop. So now I'm trying to chop the nucleus. This is a grade 5 cataract. Once we have the first quadrant, you will see how dark and how black the cataract is. Of course, I'm having some difficulty in the first chop, but once the first chop is done, this is very important, because if we don't have the primary chop, we will keep rotating and have damage to the zonules. So now you see, the first quadrant is almost out, and once I pull it out, yeah, you see how black it is. So now the femto really helped us, one, in giving the rhexis, second, in making those grooves within our nucleus that we can help in chopping and breaking nucleus. This is a grade 5 always cataracta nigra, you see. And once we have that, and of course, after every quadrant, using dispersive viscoelastic. And once that is done, it's pretty easy, we can go and put a lens. There are of course certain intraoperative complications, difficult situations during nuclear emulsification. It's a hard cataract, tenacious cataract, you won't be able to break it. Incomplete separations will of course give you more manipulation, damage to the zonules. So the diabetic cataracts, hard cataracts are tenacious, difficult to break. Absence of any epinuclear cushion, like I said, once you don't have the epinuclear cushion, you can always have a PCR. So be very careful, try and keep filling your bag with viscoelastic. So this is a small video, I'll just show how I took an ASOCT in a dense cataract. You can see how when I focus my ASOCT on this intermission cataract, you can see how dense the cataract is and how shallow the AC is because of density. You see, this is the anterior capsule and how density, look at the fluid within this capsule. I'm not showing the surgery, but I just want to show you how dense the cataract is, and using the ASOCT you can see the density and the thickness of the cataract and what problems you are going to face during cataract surgery. So intraoperatively you can have a PC tear, so you should always have a retina surgeon on call or have a vitrectomy probe, so you can do an intractable vitrectomy. Early detection of the PCR very important. Management depends on the stage where you see, and of course as soon as you always have to follow the simple rules, as soon as you see a PCR, don't withdraw your probe, take visco, stop the herniation of vitreous, and then you can manage your PCR from there. Dr. Ramamurthy will be speaking on management of PCR, and anterior vitrectomy is required. And just some considerations. There is a prolonged surgical time. Explain to the patient that the patient, you might require a block, though 80% of the cases can be done without any block. They can be done in topical anesthesia, especially the femtosecond laser. There can be increased risk of AC inflammation, corneal inflammation, CME. Patient has to be explained, and post-operatively might have to increase or upscale your steroids and might even need to give a systemic steroids just to decrease the inflammation. IOP monitoring is very important. That also has to be considered. Thank you.
Thank you very much, Dr. Raghav. Are there any questions or any comments from anybody in the audience on hard cataract? So, actually a hard cataract, as has been very elegantly told by Dr. Raghav, is something that needs patience and perseverance. And the most important single step that I'll wish to say in hard cataract is that you need to break the backbone or the spine of the nucleus. Till you do that, there will be interdigitating fibers and you will not be able to do a phacoemulsification, which is obviously going to cause a lot of endothelial damage, etc. Now we have none other than the master surgeon of phacoemulsification, Dr. J.S. Tityal. I will always hold him in high esteem as one of the most proficient surgeons in India, and he is the chief and the head of department of ophthalmology at RP Center for Ophthalmic Sciences, and he'll be talking. He has really a lot of fantastic videos, and he'll be talking about another difficult situation, and that is the posterior polar cataract. Over to you, Dr. Jeevan Tityal, please.
Good afternoon, friends, and thank you, Professor Mahipal, sir, for involving me in this particular instruction course on cataract difficult situations. Posterior polar cataract, we do see them, quite oftenly in your routine practice. And most often, when you see the patient would have gone to 2-3 physicians, then they come to you and they always have a query in their mind. Would my surgery be uncomplicated? Would desired implantation IOL be possible or not? All those things has to be answered effectively by our surgical skill and analysis of these patients preoperatively. We all know posterior polar cataracts does have a challenge because the posterior capsule might open up during your surgery and your difficulties might start after, you see those PCR or a defect happening in these cases. The incidence may not be very, very high in a very experienced hand, but it can range up to 36% in difficult scenarios. Therefore, it is important for all of us to really see these patients and look for a high-risk cases, which are those situations where risk factor can be much more. So these are various presentations. This particular case looked like a typical posterior subcapsular cataract. But see here, it is a typical ring-shaped or onion ring peeling appearance there. And this is a case where you already have a PC which is defective and the whitish appearance and little granulation towards the posterior side is a typical feature of an open posterior capsule in a posterior polar cataract as such. So this is the density of nucleus. Denser the nucleus, more chances of complications happening in your patients. This is not only the posterior pole disc, it is the nuclear grading hardness also important for these patients. Any posterior polar disc more than 4 millimeters in size will have a higher chances of PCR happening in these cases. Therefore, apart from this written examination, we require to do an assessment for an entire anterior segment. As you just saw a beautiful IOCT picture. Similarly, you can do an anterior segment OCT examination for these patients and see what type of appearance you have. So this is one of the anterior segment OCT picture where you look for a posterior capsular visibility and the size of a disc in these patients and then categorize them in terms of difficulties which may be there in these cases. So this is a publication from RP Center where we could find out 3 important configurations in the anterior segment OCT picturization. You can say this is a conical shaped anterior segment OCT picturization. This is a moth-eaten type of appearance and this is the ectatic type of picture you can see in our anterior segment OCT. So these 3 patterns are very high risk patterns associated with high incidence of PC opening during your surgeries, which may range from the 80 to 100% in these cases. Therefore, the pre-op examination, as you saw, is very critical for all difficult cases, especially for posterior polar cataracts. Then you have to analyze intraoperatively also. If you have access to intraop OCT in the microscope, you can see them. And this is our grading classification done in a series of posterior polar cataracts, looking for a clarity of posterior capsule and a disc in these cases. And this is the type 1 we classified where you can see the posterior capsule right from the periphery center all around. So these are type 1 where clear delineation of posterior capsule. This is type 2 where periphery you can see the posterior capsule very clearly. But central area you are missing the posterior capsule appearance. And this is type 3 which is according to AIOC, this is a moth-eaten appearance. You can't see entire area of visibility, no posterior capsule can be visualized. So these are high risk cases as such. So this is intraop OCT. If you see, we have done a hydro delineation which is classically described for posterior polar cataract. You can see space created here and this is the area of cushion which you create to safeguard your nucleotomy for these patients. So if you have these pictures in your mind, you know that which is a group of cases where you can have high incidence of posterior capsular defect. There is always a teaching that you should do only delineation in your patients, avoid hydrodissection. But as I showed, if you have a type 1 variety of a posterior polar cataract, you might do a hydrodissection in those cases also. So these picturization or a morphology visualization with anti-segment OCT or IOCT microscope will give you what type of case you are dealing with, which type of posterior polar. This is one picturization in all posterior polar cataracts. Sometimes you see this defect after you finish your nucleotomy and this is called a pseudo defect. Sorry. In fact, we have described this as a typical posterior polar cortical disc defect because this comes after the nuclear aspiration. If you see this disc defect, you are pretty sure your posterior capsule is intact. And you saw here, we saw in almost 87% and no PCR in these patients. But if you don't see these defects, like this is a case where you could not see the defect and chances of PCR is very high. So if you don't see a defect after your nucleotomy or aspiration epicortex, you have a high chances of tear because the entire disc is attached to the posterior capsule in these cases. Then I think it's important to do a very safe nucleotomy in these patients. If you have access to a femtosecond device, cataract device, then you can do a typical pattern. You have a rings of safety, that is a laser delineation. And you can do a fragmentation also. And you can appreciate the posterior pole also in OCT. And Dr. Mahipal has nicely published this particular aspect of using the OCT in a femtosecond device to see these patients also. And in this way, we can always have a first tier, second tier, three tier safety, and each pieces can be taken out. As we can see in this video, you don't have to do a hydro procedure. You separate this piece, which is pre-fragmented, and bubble comes out and it delineates further. So I'm taking out the first row of our nuclear pieces. This is called layer by layer nucleus fragment disassembly. And simply with your second instrument, you can peel off the pieces and complete your nucleotomy without doing a hydro procedure. And at the end, you can take out the epicortex and complete the surgery in these patients also. Similar surgery can be planned and made in a normal phacosurgery also by doing a good assessment pre-op and intra-op also, and do a hydrodelineation in these cases and do a safe nucleotomy. This technique is published in AIOC. People have access to video also. What I do, I'd make a little trench in the center so that I can make a one chop. You can know that we can't rotate the nucleus because delineation is not complete in such cases. Take another pi of a nucleus. So this gives a space for fluid to seep into the between the endonucleus and epicortex in these cases. And this space gives you, now you can just tumble the nucleus from other half without rotation. So you have avoided the rotation of a nucleus and the epinucleus core, which is attached to the posterior capsule, and this is how you can safeguard your posterior capsule in these cases also. Just to show the same here again, you can see I'm doing a piece taking out here, then I'll tumble out. This is a space where the fluid is seeping through. You can see AIOC here, the fluid has already seeped in and given a space for the nucleus to be rotated here. So such cases are there, especially this technique is very useful when you have an open posterior capsule cases here. So this is a one posterior polar cataract. You can see a typical onion peel appearance. And if you see this particular case in the OCT, this will be a moth-eaten pattern of a posterior capsule. You can see here no visibility of posterior capsule. Do a typical rexis, which should be around 4.5 to 5 millimeter. Do hydrodelineation. And subsequently, you can do a chop and tumble technique, which we have described in such case. In this particular case, we had the opening of posterior capsule during stage of hydrodelineation. So we'll do one chop here, do another chop in a sidewise. This will give you a space for a fluid to enter into a space between endonucleus and epicortical cushion. Subsequently, you can just tumble the pieces to central area and complete your nucleotomy. You saw that nucleotomy is complete here. Now I'll take out the posterior support of epinucleus, which has been taken out. You'll see at this stage that the posterior capsule is open here, but irrigation on is pressurized. You can take out the cortex. Before you come out, you should inject the dispersive viscoelastic to tamponade the anterior face of vitreous in that and do a bimanual aspiration of remaining cortex. Fill the chamber with the dispersive viscoelastic to maintain the pressure. Enlarge the incision a little bit so that you can inject the lens, not wound assisted, into the anterior chamber. Open the lens over the rexis, then shift the rexis, these haptics gently under the rexis, and this is stabilize the IOL in the back. So this is a technique when you have this leader opening in the central area, you can still do an implantation IOL without difficulty, and this is possible because you could do a nice nucleotomy in these patients. To summarize, I have covered the pre-operative assessment to look for a risk assessment for your cases. Then intra-op way to look into a IOCT guided assessment, which can also give you an assessment for a PC rupture during your any stage of surgery. Then look for a safe nucleotomy where you can preserve the epicortical cushion till the end without rotation, and towards the end remove the epicortical cushion in bulk. If you have a tear also, you can manage subsequently also. Thank you for your kind listening.
Thank you very much, Professor Tityal. Always, yeah, go ahead. There's a question for you. Can somebody give a mic, or maybe you speak, I can repeat the question. Mic de do.
After putting the lens in the capsular bag, generally when there is no PCR, we boldly go under the lens and remove the viscoelastic. In your case, whether you will advise to remove the viscoelastic or we should leave it like that because already the PC is ruptured, one case. And if you leave it, then generally you will follow it for any spike of increase of pressure. Or still you will like to remove the viscoelastic.
I think very good question. Thank you, sir. In these cases where you have a PC opened up, you have seen I've used, dispersive viscoelastic to tamponade that first. Then use the cohesive viscoelastic to maintain the chamber space as well as the posterior space also. And the viscoelastic in the bag was very less because I opened the lens over the axis. Then subsequently tucked the haptic inside. So you have a little viscoelastic underneath the IOL. And you don't have to go behind the IOL to remove the viscoelastic in these situations. Whatever viscoelastic can be removed over the IOL is good enough to support this. You may have a IOP spike in such cases, and you should be prepared for that. Maybe you give a diagnosis for these patients for first day, see next day what is the IOP, then you can manage subsequently in these cases. And in those cases where we have to do other procedures, then it's a totally different way to assess these patients, because I have another session of posterior polar cataract where posterior capsule opens up, how to implant, how to fix. That will be next session, and you can join in that meeting also. Thank you again.
Basically, even at times when you are doing hydrating the wound, at that time the pressure has been enough to cause a rupture of the posterior. You have relaxed and you have said everything is fine, but then the PC can give way. So your question was really very good, that you should not be over adventurous to take out a lot of viscoelastic if you have been able to do. But what Dr. Tityal has highlighted is the importance of pre-operative assessment. We normally ignore that. The incidence of nucleus drop, etc., has gone down significantly if we are looking at these particular things. Even the IOL Master 700, the OCT also can, in the OPD, can give you good indicators whether there is a pre-existing rent or not, and accordingly he has shown various techniques to not have a nucleus drop and using the epinucleus as a cushion. In our hands, as he has shown, we prefer the femtosecond laser, and several reports have been published that if you have a femtosecond laser and you are doing a posterior polar, the incidence of nucleus drop has almost gone down to 0%. So, thank you very much again, Professor Tityal. We now go on to another young surgeon, Dr. Gitansha Shreyas Sachdev, and she works at the Eye Foundation, and she'll be talking about femtolaser. I think more and more people, there has been a growth in the number of procedures of femtolaser between last year and this year of more than 100%. That's the growth that you have of the number of procedures that are being done. So she's going to talk. Sure. She's going to talk about femtolaser assisted cataract surgery in complex cases. The normal cases of cataract surgery can obviously be dealt with the femtolaser, and often people feel that there isn't much of a difference, but it is when you are dealing with complex cases that the real power of the femto comes into play. So over to you, Dr. Gitansha.
Thank you. A very good afternoon to all of you. So my talk would be on femto-assisted cataract surgery in challenging cases. I have no financial disclosure. Now we're all aware that femtosecond has brought about an unparalleled accuracy and precision over the conventional phacoemulsification. But do all these advantages, such as a precise capsulotomy, a lens fragmentation, hold good in complex cases? Well, the answer is a resounding yes. So over the subsequent slides, I'll be showing you certain complex cases wherein we used the femtosecond laser. The white cataract, as we all know, is a challenging case. One of the major challenges in the wide cataract is to initiate and get a proper capsular access. The increased intralenticular pressure along with a poor red reflex very often increases the risk of a runoff, or what we call the Argentinian flag sign. Additionally, there are times that there might be an associated fibrosis or a zonulopathy. So how the femto helps here is that the most challenging step, which is the capsulotomy, can be done with relative ease. This is also important in premium IOLs, where it's very important to have an accurate ELP. The femtosecond here works in a closed system, so it delivers a precise capsulotomy every time. The important thing, however, is to always stain the capsule with blue, because sometimes that sudden egress of fluid from within the lens can obscure the underlying structures from the femtosecond delivery and result in certain uncut areas or tags. These can easily be dealt with by either using a cystotome or a rhexis forceps. The femtosecond, however, does not penetrate very well in these waterlogged intumescent cataracts, and the nucleotomy may be slightly suboptimal. When we're moving on to the hard cataracts, we know that this is a challenge because of the increased risk of a posterior capsular dehiscence and also because of increased risk of corneal endothelial damage. So the femtosecond cataract helps in both of these conditions. Various studies have shown that the effective phaco time is drastically reduced when we use the femtosecond nucleotomy over traditional phacoemulsification, and this advantage is even better when the grids that are used are a smaller size. Again, the advantage is better with higher grades of cataract. So this is a LensX system wherein you can see a matrix pattern which essentially breaks down the nucleus into very, very small cubes by multiple vertical cuts with two interspersed horizontal spiral in patterns. So what you're left behind with is a very easy nucleotomy which requires much less phaco energy, and what you get are clearer corneas and reduced postoperative inflammation and obviously a happier patient on day 1. So this is an example of a rock hard cataract. It's about grade 4 to 5. This is just to show you that the femtosecond laser actually penetrates throughout the entire depth, and it gives you grooves which are sufficient enough to make the cleavage very easy subsequently. The bubbles that you saw which were released were as a result of the Nemo dissection that the femtosecond laser induces. The next one is posterior polar cataract. Dr. Tityal has already very eloquently and comprehensively covered the entire use, but I'll just touch over. One of the more important things that this helps in is that it avoids the need for a hydrodelineation, because the femto lasers, in a sense, produce a slight amount of a pneumodelineation. And the other important thing that Sir had pointed out was that in these cases we can leave behind a thick epinuclear sheet. So how that helps is it's kind of like a cushion to the posterior capsule from all the hydraulic forces that take place while we're doing the nucleotomy and removing the central core. The AIOC is also a very useful tool which allows you to see before you enter, and the posterior capsule can actually be imaged to get an idea of whether it's intact or if there's any dehiscence before the surgeon actually enters the eye. So we had published this. It's a result of 50 eyes who had undergone flax with PPC, and we saw that there was 100% negative predictive value, which means that in the eyes in which the posterior capsule was intact in the AIOC, none of them had an intraoperative posterior capsular dehiscence. So this is just a short video. You can see that this is a posterior polar cataract which has already a pre-existing posterior capsular dehiscence which can be seen on the slit lamp. So we're using the catalyst system in this to dock the eye. So this is what I was alluding to earlier, wherein the AIOC actually gives you an image of the posterior capsule. And here you can notice that there's an area of defect or dehiscence in the posterior capsule which kind of warns the surgeon beforehand that there is an increased risk for the capsule to give way. So very important step here is to increase the posterior offset of the nucleotomy to get a thicker epinuclear cushion or sheet which will protect this posterior capsule while the nucleotomy is happening and while the central core fragments have been removed. The vitrectomized eye is another challenging case. The silicone oil in the posterior chamber does obviously change the red reflex, and also it increases the pressure wherein it's harder to get the capsular rhexis. There might be additional epithelial, corneal endothelial compromise, or a posterior capsular touch or a zonular weakness. So the femtosecond laser, again, like in the PPC, helps you to see the posterior capsule. Again, the posterior offset of the nucleotomy should be raised to give a cushion. You can see that in this we're doing a capsulotomy and the nucleus has been fragmented into 4 quadrants. Again, this nucleotomy will drastically reduce the amount of phaco energy that one is using, which will give better results vis-a-vis the corneal endothelial damage. So you can see the red reflex of the silicone oil once the cataract has been removed, which is followed by an intraocular lens implantation in a well-centered capsulotomy. A word of caution, however, in these is to look for emulsified silicone oil in the anterior chamber, because there are certain cases wherein this emulsified silicone oil might be present. This will interfere with the subsequent delivery of the femtosecond and result in uncut areas underneath, as you can see here, in terms of the capsulotomy as well as the nucleotomy. So in these cases, perhaps it might be better to avoid a femtosecond laser and proceed with a conventional phacoemulsification. Glaucoma or high intraocular pressures was considered a relative contraindication for the femtosecond laser because there was an increase in the intraocular pressure during the dock. However, with the advent of the soft fit PI and the liquid interface, this is no longer a contraindication as the intraocular pressure rise is now much lower. The only important caveat that one needs to remember here is that the suction ring has to slightly be decentered to make sure that the area of the bleb falls within the ring so there is no suction loss, and also there should be no damage to the conjunctival tissue. You can also appreciate the bleb that was there on the ASOCT imaging. So this was just followed by, the rest of the steps are normal with the normal capsulotomy and the nucleotomy that the surgeon prefers based on the grade of the cataract, following which the remaining procedure can easily be done. Another contraindication was a small pupil because this essentially limits the capsulotomy that one can do and the nucleotomy within. But now it is also possible to insert these pupil expansion devices. Like you can see that the Maligan ring is being inserted in this case, after which the patient can be shifted under the femtosecond dock. You can see here that the Maligan ring has allowed an adequate pupillary dilatation, and we are able to plan a 5.5 millimeter capsulotomy and an adequate nucleotomy with that. So I just like to conclude that the technology of FLACS has evolved to find widespread use not only in conventional cases but in all forms of complex cases. And it's time to take the leap of faith and finally switch to the power of femto. Thank you.
Thank you very much, Dr. Gidansha. Any comments or observations or questions? So she's very eloquently described and shown videos as to how complex cases are made simpler by doing the femtolaser resisted cataract surgery. Obviously not all of you or all of us have the femtolaser, but I think with the prices of the LOIs coming down over time, I think the percentage of patients getting the procedure done through femto would increase. Let's go on to Dr. Ramamurthy now.
So I had a question.
Yeah, sure.
I had a question.
Yeah.
So when we talk about the posterior polar cataracts and
Yes.
we talk about non-flex cases where we are doing hydrodelineation versus in flex where we are doing femto delineation. So in femto, because we are not going to, do hydro in those particular cases after we have done femto.
Yeah.
So how do we ensure that the air or the gas buildup is released and it does not affect the already thin posterior capsule?
So the first thing, the question is that it's not it's basically a pneumodelineation that happens, and that's automatic, that a pneumodelineation, because there is going to be the areas of unison where the gas would go, right? So what you have done is that you have seen that whether there is a posterior defect or not, and you have raised the level from say a 500 microns as the offset to maybe 800 or 1000. Once the offset is raised, the pneumodelineation is going to come at a level which is much higher than the posterior capsular defect, if at all it is there. Do you understand? It's not going to go below that. It will go above the epinuclear cushion. So there is no rupture that happens of the capsule. This is absolutely clear. This was, if the offsets were lower, this Lawless had reported that pneumodissection causes a rupture, but that was when they went back and saw the default settings were not 500 microns. So if your default settings are very low, then only you can have, otherwise the cleavage goes along the area where the epinucleus and the nucleus meets. So there is no need for any hydro procedure at all. The pneumodissection in itself is sufficient, and the pneumodissection never ever breaches the epinucleus, because the epinucleus is strong enough. See, when you are doing a femto-LASIK or you are doing a smile, it is at a micron level that you are working. Okay, so the point is that if you are cutting a flap, it's not that you are having the cavitation bubble go deep down, it's only at that limited plane that you have the bubble. So similarly in this, it will go between the junction of the nucleus and the epinucleus.
So in this case with flex, you should, the kind of parameter or the thing that you are using strategy, it should be circular cuts versus, or you can use any
that
pattern.
Doesn't matter. The point is circular cuts or whatever is just giving you concentric cuts so that you are going up to the outside. So Lensex gives those circular cuts. In our particular case, in say Catalyst or whatever,
So
you can get a grid pattern, but you can get circular also. You can skin the cat in many ways. There is absolutely no issue on that. It is just a question that you are making it into segments, so that as you keep on taking away the central core nucleus, there is no manipulation. Then you take out the next core, and then you take out the next core in concentric rings. It's only at the last stage that you are going to disturb the epinucleus. So therefore you never have a nucleus drop, because the epinucleus is like an airbag that you have say in a car. So it's going to give you a protection.
It also depends on the grade of the nucleus. Like posterior polars usually, apart from the polar component, are actually very soft cataracts. So in soft cataracts, it's okay to just kind of divide it into either quadrants or sectants and not go on with the grids of those quadrants, because it's harder to get a hold also while breaking it. Also, another important thing to remember is the more grids we form, or the finer grids we form, the femto passes more, so the pneumodelineation and the amount of bubbles that are releasing will also be more. And in normal cases, it's just simple. All you do is gently just push it down or nudge it a little bit, and you'll see those bubbles actually escape before you proceed with the rest of the case.
Thank you. We'll go on to the next speaker, and that's none other than Dr. Ramamurthy, who is a great surgeon. He's been the past president of All India Ophthalmological Society, as also the past chairman scientific committee, and he heads the Eye Foundation group of hospitals. He'll be talking about management of posterior capsular rent. So this is something that we all have. The best of surgeons have posterior capsular rents, and you need to manage it and not lose your cool. So over to Dr. Ramamurthy, please.
Thank you, Dr. Mahipal, for having me in this course. I'll be just showing you a bunch of videos with this posterior capsular rent. This is the only written slide that I have. The immediate goals of whenever you are faced with a situation is to extract all of nucleus, and if it's not possible, if it drops down into vitreous cavity, please don't chase it. Allow a vitreoretinal surgeon to intervene. Remove the cortex and epinucleus as completely as possible. Do an adequate anterior vitrectomy and preserve as much as possible the residual capsular support, whether it's the anterior capsule or posterior capsule. And if it is possible, implant the lens on the capsular supporters that is there. In case it is quite inadequate, either in the same sitting or another sitting when you are better mentally prepared, or you have a senior surgeon helping you, or instead of topical you have a peribulbar anesthesia, go ahead and do a iris clip lens or a scleral fixated intraocular lens. Once handled adequately, these cases do extremely well. And I think all my videos in this presentation are going to be running at 2x speed, so don't be bothered by the abruptness of the movements. I'm going to leave you with start with a message of hope. In the sense, this was a patient, physician from Ooty who came to me almost 2 decades back when he was 78 years old or something, and then we had this surgery going on. And as you can see over here, there is a fairly large PC rent that's there, and you can see the type of instruments that we're using. And anterior vitrectomy was done, and subsequently viscoelastic was injected in just in front of the capsule, and there's a 3-piece intraocular lens that is going in. Mind you, this video is almost a couple of decades old, and I had this. This was a premium patient for me at that point of time. That's the intraocular lens which is placed in the. You can see a blob of viscoelastic which is behind. And before you create an optic capture, you have to remove that viscoelastic. Go behind, whatever little vitreous is there, that's also removed. There's no triamcinolone acetate that was available. Very clearly you can see the area of PC rent and a fairly stable lens. And this picture was taken when the patient was almost 94, about 16 to 18 years later after the surgery. And no, this was soon after the surgery, and you can see with the PC rent and the way the lens has been implanted. And this picture is almost 18 years after the initial surgery. The patient maintained an excellent 6/6 visual acuity right through. So just because you have a PC rent on the table, at that point of time, our understanding, the kind of equipment, instruments we had available to us was also not as superior as what we have today. Once properly handled and you limit within your own capabilities, most often you end up with optimal results. This is a very small video clipping again, where the importance of not taking out your irrigation cannula till such time as you inject a viscoelastic is there. As far as you see a small PC rent that has occurred, as far as my irrigation cannula is inside, that was just flopping around. But the moment I take it out, the anterior hyaloid moves forward and immediately you get a PC rent which is extending. So obviously the most important aspect when you face a situation like this is to go ahead and whatever is the if you have a dispersive viscoelastic, that's the way to go. Just in case you do not have access to that, then at least even a HPMC will do. But it's extremely important to reform the anterior chamber. And this is just another situation where you will see that while I'm polishing the posterior capsule, there's a fairly large rent that occurs in the temporal aspect. Now I'm doing the right thing in the sense the irrigation cannula keeps flowing inside. I'm injecting a viscoelastic, HPMC, and then subsequently the intraocular, single piece intraocular lens goes inside. So even in a situation like this, when the lens is being injected into the bag, it's possible to stick on to your original plan of injecting a single piece lens. And as far as the anterior hyaloid is not disrupted, there is no need for you to really do a anterior vitrectomy. I ensure that the lens is well placed within the bag, hydrate the incisions with the irrigation cannula in place so that there is no anterior movement of the intraocular lens, and that's the end of surgery. Here again, I'm quite confident with the way this patient has been handled. He is going to retain a good visual acuity for the rest of the lifetime of the patient. Most often, it's a posterior polar cataract where you end up with a situation like this. Everything seems to be proceeding fairly smoothly. Obviously, a 5 millimeter rhexis, no hydrodissection, just hydrodelamination. I do a stop and chop in this particular case, and that's not really an area of rent that I have created. It's only a deep trench. I bisect the nucleus, and as you'll see at the end of this, the posterior capsule is still intact after the entire nucleus comes out. But just to emphasize the fact that the capsule is always extremely weak in these cases, a simple polishing, you can see that there is an area of dehiscence of the posterior capsule that has happened. So again, the same principle in the sense that that's dispersive viscoelastic which is injected. And as far as the rent is manageable, either by doing a posterior capsular rhexis or because it's confined to a small area, you can go ahead and implant an intraocular lens within the bag. Now, it's a very extremely important aspect that you need to understand before we take a vitrectomy in these cases. Most of these machines come with an anterior vitrectomy, and that's the first step. What exactly does it mean? That is, in the first step you only have irrigation. As soon as you go to the second step, both the cutting as well as irrigation, aspiration is activated. Now, with most modern machines, you have this IA cut and cut IA mode. When you are dealing with vitreous, essentially what you need to go on is a cut IA mode, where you cut the vitreous, then aspirate. First step is only irrigation, second step is cutting, third step is aspiration. And when you are doing this, and if you want to remove a little bit of cortex, then just in case, what you do is a IA cut, where basically you are staying in the second step and remove cortex. So you can go ahead and vacillate between these two steps to effectively remove vitreous without creating any traction on it. So please understand this concept of cut IA, where you cut first and aspirate second, with irrigation flowing right through. Nowadays, with 4,000, 5,000 cut rates being available with many modern phaco machines, the traction on the vitreous itself is very low. But in spite of it, so you can go ahead and use an anterior vitrectomy mode itself, where both cutting and irrigation aspiration is happening in step 2. But then it's always a good idea to use cut IA mode in these cases. This is the normal parameter setting when you are doing the vitrectomy. Ramp it up to the maximum cut rate that's available with your particular machine. Keep the intraocular pressure or the bottle height quite low. As you can see, it's just about 41 millimeters. Keep the vacuum as well as the aspiration low, and this would give you a more controlled vitrectomy whenever it's needed. Let's look at this case where a vitrectomy procedure was needed. And as you can see over here, I have a fairly large PC rent over there, and I inject viscoelastic, and you can see that a strand of vitreous that came in, and the irrigation is kept in the anterior chamber. I go in with a vitrector, do an adequate vitrectomy. Then even in this situation, because the rent was confined to a small area, just because it's not extending, I'm able to go ahead and place a single piece intraocular lens in the back. The small strands of cortex over there, but that even if you leave it behind, that will get absorbed over time. This is a fairly old video of mine, and that's the reason that I'm not checking with triamcinolone acetate in this case. Just in case you have a situation like this, where you are having a significant amount of nuclear fragments still remaining, and you have a PC rent, you can, things appear to be moving smoothly, an adequate capsular excess, fairly hard nucleus. Halfway through, one heminucleus is gone, but then I find that there's a fairly large PC rent that is there over there. So if the nucleus fragment had dropped inside, gone into the vitreous cavity, there's no way I would have done anything, but called in a vitreoretinal colleague to handle this. But still, since it was still approachable, what I do is to go ahead and bring the nucleus fragment into the anterior chamber, and fill in a bit of dispersive viscoelastic, and there is a 3-piece lens. The patient had a 2.2 millimeter incision for the single piece incision lens. I enlarge it to a 3-piece, enlarge it for introducing a 3-piece lens, place it inside, and with the intraocular lens itself acting as a scaffold to prevent the nucleus fragments from falling in, I go ahead and remove the nucleus, and now I go behind the intraocular lens with the irrigation in the anteriorly, and do a good anterior vitrectomy. Diluted triamcinolone, usually in the phase of about 1:3, it is what is injected, and then it's ensure that the vitrectomy is quite complete, and make sure that your incisions are bereft of any vitreous strands. And this is again a step of using an IOL scaffold. You see there is a certain amount of cortex that is over there, and inject viscoelastic with the irrigation flowing inside. Introduce the intraocular lens of your choice inside. Here again a single piece lens is possible, because I feel that there is adequate support for the capsule, remaining capsule to support the cortex, and subsequently I take out the cortical matter that is there. Just in case I had to, the capsular support was not was adequate, and I had to place a 3-piece lens, it would have been in the sulcus with an optic capture. So this is PCR that's occurring during initial chopping itself, and in this case, in the area of the large PCR, you inject dispersive viscoelastic. Viscoat is what I choose in these cases, And then subsequently, you can bring out the nucleus fragments into the anterior chamber and make sure that none of the nucleus fragments are going posteriorly, and with a spatula which is supporting, and refill the area of the PC rent whenever it is needed. It's possible even with a fairly large rent, there's refilling of the viscoelastic that is taking place. It's possible to remove the nucleus fragments quite completely. And you have to make sure, in case there is, it's always a good idea a week later, or if the visibility is good a day later, to have a vitreoretinal colleague, or if you are comfortable doing a good vitreoretinal examination to make sure there's no nucleus fragments or cortex inside. Instead of allowing this to persist in the patient's eye for weeks together, nowadays sutureless vitrectomy is possible, and this needs to be attended right there and then. There's not a single case of dropped nucleus I'm going to show, because I believe that all the audience here are anterior segment surgeons, and once the nucleus slips inside, it's beyond the scope of control, and they need to call in a vitreoretinal colleague to go ahead and handle it. And that's a 3-piece lens which is injected into the sulcus, and an optic capture is also created to stabilize the lens. And it's extremely important that you ensure that there is no vitreous stance in the anterior chamber at the end of the surgery. And even a situation like this, you can see that there is a fairly large dialysis that is there. It's always a good idea in a situation like this to put in an endocapsular ring. But even using a single 3-piece lens where the haptics are fairly rigid, and using the haptics itself to support the area of dialysis is a good idea, and that itself would take care of this. But I would recommend normally to put in an endocapsular ring to facilitate more support for the area of dialysis, and then placing a 3-piece lens. Mind you, a rigid haptics of a 3-piece lens always gives better support than the single-piece pliable haptics. Last of my videos, fairly important patient, a gynecologist, underwent LRCS with a multifocal intraocular lens in the first eye. Second eye surgery, only now I noticed that there is some amount of debris in the posterior, in the vitreous cavity. That's when you can see at 6 o'clock there is a fairly large rent because of the extension of a capsular discontinuity. Basically what I do is to go ahead through the anterior route and do a good anterior vitrectomy. Irrigation cannula is just kept into the anterior chamber, and I'm extending the incision because I do not want to do a wound-assisted implantation. Avoiding the area of PCR, I go ahead and introduce the intraocular lens in the capsular bag. I know it's fashionable today to say that we do a pars plana vitrectomy in these cases. I did try it out in a few cases, but I believe that in my 3 decades of practice, anterior vitrectomy alone with the basic principles, tenets being observed, works very well. And though doing a vitrectomy through the pars plana route is also a good idea, at least in my hands, doing through the anterior route itself is quite adequate as far as doing the right thing at the right time. Thank you so much for your kind attention.
Thanks, Rama. They were excellent cases. Now invite Dr. Mahipal, who needs no introduction. He is talking about the third hand, which is the pars plana route, which Dr. Ramamurthy just said, for an anterior segment surgeon.
Thank you very much, Kumar. Picking up from just where Dr. Ramamurthy ended, I'll be talking about the third hand pars plana instrumentation for the cataract surgeon. Just a small video clip. Audio, please.
System forms the backbone of this instruction course. It is imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valve trocar cannula set consists of 3 23-gauge trocar cannulas, an infusion pipe, and 3 scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar, threaded over which is a round-bodied cannula. Phakic eye, the cannulas are inserted 4 mm from the limbus. The conjunctiva is retracted slightly, and the trocar cannula is inserted in a 2-step fashion initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for vitrectomy cutter are plugged till further use. It is a relatively simple technique which can be mastered easily with little practice.
So now we'll be showing you some clinical cases using this particular technique. As you all know that capsulorhexis is difficult in intumescent cataract. You can use high density viscoelastic or do a mini capsulorhexis and then extend it. But obviously there are the Argentinian flag sign that can happen in these. So you can see here you're just making a nick and you can see that the capsule just opens, and this is the Argentinian flag sign which you all know. So that's going to make the phacoemulsification difficult. Also, often if you have phacomorphic glaucomas, pressures are high for a long time, the chances of choroidal effusion, expulsive hemorrhage, etc. is there. And if you do not have access to a femtolaser procedure, a femtocapsulotomy is a closed chamber procedure and you can get a good capsulotomy. In this particular case, this is a lady patient who had a lot of comorbidities, an aged lady, 56 millimeters of pressure, PR inaccurate, and despite having mannitol and topical anti-glaucoma steroids, we were having a high pressure. So how did we manage this particular case? Here we are using the help of a retina person and the same procedure that we showed, the trocar and the cannula. Mind you, we will not be entering, there is a slight decompression, that's all. You can see that with the tip, you just, whatever fluid is coming out, because there is a lot of fluid that is there, you just do it and press it here and just see that the globe became very soft. Once you have a soft globe at that particular time, you can do a controlled capsulorhexis, as you can see in this particular case. This is a smaller capsulorhexis that we are doing and we are taking it forward. You can see that we are extending it, and the ease with which we can do a capsulorhexis is obviously there because you have taken out the fluid. Now you see that we are taking out the excess viscoelastic, and because it's a hypermature cataract, it's not a hard cataract, you are able to complete the phacoemulsification pretty good. There is only the blockage. We are not putting in a lot of infusion into the posterior part of the eye, and you can see that the phacoemulsification procedure is going on very smoothly, and we are able to see. Now just watch here. At this particular time, again, you can see that there is a lot of expulsion that is happening. The iris is coming out of the wound, as you can see, and the globe has suddenly become tight. So it could be a limited choroidal infusion or more fluid that has gone in. When you are doing the phacoemulsification, just take out the cannula and you can see that you just remove certain amount of fluid and see how, without even entering the eye, and you can see that this third hand is helping you and you have a soft eye now, and we can go ahead and complete the procedure of phacoemulsification. And you can see that the IOL has been put in this particular case. We are using a cutter to do a peripheral iridectomy in this case so that the patient is relieved of the glaucoma. This is the first post-op day which you have in this particular patient. Now again, let us see the cases where we have to again face the challenge and take it head on. In this particular case, again Dr. Ramamurthy had talked about how you can use a cutter. This was a traumatic cataract. Actually, you could see that there is a rupture through and through, which is also in the interior capsule as also in the posterior capsule. And we are not able to obviously work through the anterior route. And here we can use the cutter system with either the aspiration first or the cut first, and basis on that you can use it either for aspiration or you can use it for doing the vitrectomy. So again, we are doing the pars plana approach. And you can see that in this particular case, we are using a cutter first. Can you see the cutter being used first? And in the situation where we want, in this case, when we have to take out the aspiration, in this case, we will do the aspiration first and you can see that this is the aspiration. This is being used as an irrigation aspiration just now. The earlier we had used it as a vitreous cutter, as you can see in this particular case, but this is all from the pars plana. If you are coming from the anterior route, you are hydrating the vitreous and the vitreous keeps swelling and coming out. So it is always better to go in for the pars plana route, because you have seen that this was a traumatic cataract with both anterior and posterior capsule rupture. And then we can go ahead, once we have cleared everything, we can put tricot and we can put a 3-piece lens as we are putting, and do a capsular capture in this particular case and get out. Now this is a doctor patient who came to me from Patna. Post-traumatic subluxation, you can see there is a huge subluxation again, and if you watch carefully on the slit lamp, you could see, and if you watch, can you see the iris falling back? And this is, here you can see that there is a vitreous blob which is there. So there is a vitreous that is herniating from there. There is the iris falling back, and we are using the power of the femto in this case. So you have to have the bubbles coming on the interior and the posterior capsule so that you get a good capsulotomy. Again, you can do a customized capsulotomy. That means that you will putting a ring, then the whole thing will come. So you can actually do a capsulotomy which can be limbus based, which can be on the scanned capsule, or you can customize. So you can see if I am doing it eccentric, it is coming on the iris. So we are going on to a customized capsular access. You can see I am moving it, getting it into the center so that I do not hit the iris, and then I can enlarge the size of the capsulotomy basis what it is. So you can see here that once we are settled with the capsulotomy, this is this is the capsulotomy that has happened, this is the nucleotomy which has happened, and you can see this is the situation. So again, I am prepared because there is vitreous already. We are using the trocar cannula in this particular case, and you can see we go from the posterior approach, remove the vitreous. There is obviously tricot that has been used. Whatever is the vitreous which is there, we are removing. We have a good capsulotomy. We have a pre-cut nucleus. So this is the advantage that we have, that our intraoperative manipulations will be less. You can see the huge subluxation. Now I go in with an endocapsular ring, and this is an endocapsular ring that is being put so that we are shifting the whole cataract complex towards the side so that no more vitreous comes. And you can see with very gentle aspiration, nucleotomy having been done, you are just doing a phaco aspiration. I would say very little phaco is being used, and you can go away and get all this particular thing out. And this is the irrigation aspiration that is being done. Bimanual is being used because it is more gentle. We had the ring, and we are using a 3-piece intraocular lens which we are putting in this particular case. And now whatever is the residual vitreous, we again inject tricot, and from the other port we are removing the vitreous strands which are coming into the wound, which is into the side port. Remove this and then go ahead and do a vitrectomy for removing, and this is the post-op picture you have. So until, of course, we had not followed the posterior approach, we would not have got such a thing as we have in this particular case. Now, I think I'll leave this. This is on retroillumination, on chandeliers illumination, and Dr. Shreyas is going to talk about it. This is again a fantastic technique just to show you that a chandelier's endo-illuminator can be pushed using a peripheral approach, and you can see in corneal opacities you get a fantastic outcome. You can see how well it shines through, and this is again a chandelier's approach where you are putting a light back. Shreyas is going to talk about it, so this is a gunshot injury, and we are able to get good results. So friends, this is again to show you another case. So all that I am trying to say is that the help of a pars plana route and a posterior segment, this was the gunshot injury that the patient had, this is in a case of DSEC, that you can actually get great results in difficult cases of phacoemulsification when you are using a posterior segment approach for getting such outcomes. So with that, I end my presentation. Thank you very much for your kind attention. Thank you. Any questions for me? Okay, we now go on to Dr. Kumar Doctor, who is again an excellent proficient, one of the early adapters to phacoemulsification, has a large volume practice in Mumbai, and he'll be talking about rings and hooks when you are dealing with a small pupil. Kumar.
I'm the fill in the gap, and Mahipal told me to get this out, so Thank you, Maipal. I'm talking on behalf of my friend Gaurav. This is about rings and hooks. So, the unfortunate part is there is no control here. So anyway, this was a triple procedure, so you need to do everything together. So here you can put various methods of using the hook. So, here what I'm showing is a diamond method of putting the hook. So then there's something else. So this is just creating four things, and then you can have a diamond method, you can have a square, you can have a rectangle, just to show you that this is one way of doing it. Bar, he doesn't know how to do it actually. The next guy, the next step here. वो कैसे करा? ये जो बार आता है ना नीचे, ये बार आना चाहिए ना. Normally वो arrange होता है ना, एक ही screen पर आना चाहिए. Show live video hoga. Always show live video. It will show the bar.
Kumar, shall we ask Shreyas to present? You just
no, I'll just finish it now. Anyway, it's not working. They can't arrange it.
Maybe they can in the interim. Shreyas, I'll just ask Shreyas to present on through hazy corneas. Can you just give this thing? Iske baad. Can you put his
वो बाजू का कनेक्ट कर दो.
ये कनेक्ट कर दो इधर वाला.
ये तो मैंने किया नहीं, फिर भी नहीं हो रहा है यार.
Okay, Dr. Shreyas is obviously the Gen Next at the Eye Foundation, doing great work, cornea, refractive surgeon, cataract. He'll be talking about phacoemulsification in hazy and compromised cornea, I think from where I left. He is going, over to you, Shreyas.
Thank you so much, and it's a pleasure and honor being part of this course. Over the next few videos and presentations, I will take you all through different situations where decision making is nearly as important as the surgical skill itself. Now, this is a patient who is a post-corneal tear repair. As you can see, it's a fairly vascularized scar. The visibility in the inferior half is poor, and there are some amount of synechia. Now, in these cases, the cataract will be soft, but the idea is that the capsule can be quite deficient. So it's important that we do a cataract with very low settings and also anticipate the chance of having a posterior capsular tear at all points of time. Now, in all these cases, the hydroemulsification is to be avoided. We do gentle teasing maneuvers, prolapse it anteriorly. Fortunately, here there was no rhexis extension. But if there is an extension, you need to have a 3-piece IOL standby before you do it. With regard to IOL power calculation, we wait till all the sutures are removed and attain a period of stability. Generally, because of the irregular nature of these corneas, we avoid any type of toric or premium IOLs. Now, this is a patient post-Stevens-Johnson syndrome. The idea is not just to talk about Stevens-Johnson syndrome, but any ocular surface issue in the setting of cataract. It's very important that we don't proceed with the cataract surgery directly, but address the ocular surface first. It might just be doing a temporary tarsorrhaphy, it might be doing a mucous membrane graft, it might be doing an amniotic membrane graft as per the requirement of the particular situation. But once the surface has been stabilized, you can then go ahead with your cataract surgery very safely. Because in the post-cataract surgery period, when you're using topical steroids and NSAIDs, only if the surface is stable will you not have any major issues, you can avoid disastrous complications like corneal melts. Now, again, when the view is a little compromised, it's important that we use all our maneuvers in our armamentarium, like doing a hydro maneuver will have to be limited. When you're completing your rexus, you have to ensure that it is removed in its entirety. Ensure you complete the rexus away from the region of the scar. These are certain basic things we can keep in mind. Tilt the globe a little inferiorly and use so that you are able to visualize in the superior half and do the cataract surgery. As you would have noticed, I would suture all ports in all these compromised corneas as they tend to have a lesser tensile strength and there is a higher chance of wound leakage in these corneas. Additionally, as you can see here, speculum may not always be possible and you can use some traction sutures to give you adequate visibility. These cases, we are trying to achieve the best possible scenario. By removing that cataract, obviously this patient will not get 6/6, but with a scleral contact lens, even in such difficult situations, we can give them adequate outcomes. Now, this is along the lines of what Dr. Maipal was also showing earlier, where essentially this is a failed graft. I'm planning to do a triple procedure, that is a cataract with a DSEC. Now, to remove the amount of corneal edema temporarily, we can use a little bit of glycerol. This improves the view. Apart from that, we can use chandelier illumination as well. Chandelier illumination is preferred over using a lead pipe on the side when you have a diffuse haze. When you have a focal scar and you need to visualize under the scar, then using the light pipe along the side, along the limbus might be useful. But when you have a diffuse haze like this, in the case of a failed graft, a chandelier illumination gives you good advantage. The main importance in this situation is that you're able to do a safe in-the-bag phacoemulsification, place a lens inside the bag. This is very important in our subsequent DSEC surgery, because while we are doing all these air maneuvers, we don't want the IOL to be popping up forwards. So if it is safely in the bag, it makes the entire procedure a lot easier and you can achieve a very good outcome and a very stable chamber with a DSEC. Again, suture all the ports, including the pars plana ones, and ensure that there is no wound leak. Again, in this situation, you might have to take, I'll just show two videos contrasting each other. In this case, where I'm combining it with a penetrating keratoplasty, another situation where I won't. Now, this is a patient who has good vision in the other eye. This is a scar post bacterial keratitis. There is no vascularization, excellent prognosis for a graft. So I just trephine 2/3 and just leave it like a flap, leave it like a cover, and then subsequently you can go ahead and remove this bulky nucleus and place IOL, and once the IOL is placed, you can remove the rest of the corneal button and then go ahead with the surgery. This is a patient with adherent leukoma. Now I'm showing two situations where we would not want to do a graft. Now this is adherent leukoma where the patient has had this adherent leukoma from childhood. It is this posterior subcapsular cataract now which is hampering the patient's vision. So even if we do a PK, we are actually subjecting the patient to an unnecessary graft because they are not going to regain the kind of quality of vision which an acquired corneal scar can achieve. So in these cases, just tilt the globe a little inferiorly or away from the area of your incision. You'll get sufficient visibility to complete your maneuver and do a safe phacoemulsification, and the patient will continue to visualize through the superior half of the cornea as they have from their childhood. This is again a patient, a 71-year-old male, one-eyed patient. Other eye is already a failed vascularized graft, absolute eye. This is a neurotrophic cornea which developed a secondary bacterial infection resolved with scarring. Now again, in this case, while you might be tempted to do a PK with a cataract, it is important that we give them good ambulatory vision for their lifetime rather than giving them excellent vision just for a few months. Because these, again, neurotrophic corneas, the graft would be very high risk, and these are good situations where you would avoid doing a corneal graft and then just go ahead with a cataract surgery. This is a fairly dense cataract, and it is important that we use good retroillumination or chandelier illumination technique to do the surgery. Again, the chopping maneuvers, again you can tilt the globe away from the scar, just beyond the region of the scar. Even if your entire probe is not visible, it's important that your tip is visualized all the time, and you ensure that the chopping maneuvers are made where you can see and visualize the cracking. Once the cracks are completed, only then should we proceed, because in these cases, when the crack is not completed and we try to pull the hard nucleus above, we might inadvertently cause a zonular dialysis, and that can become very difficult and challenging to manage in an already compromised cornea. So it's important that we perform adequate chopping, ensure that the pieces are completely separated, and only then bring them, prolapse them anteriorly, and then do, once we know that the piece is free, then go ahead and do a phacoemulsification. With all the advanced phaco techniques that we have, these are all very stable machines, whether you're using a Centurion or a Signature or any of the advanced machines, they'll give you a very good stable chamber. So even if you're not able to visualize the tip all the time, as long as you're keeping it in the center and doing the phaco, you will get excellent outcomes. This is just a last video, just briefly showing that it's not always that you have to do a graft. Now, this was a patient after a therapeutic graft who had intumescent cataract, possibly a minor rupture during the therapeutic graft which has happened. Now, because of the anterior synechia and the intumescent cataract and the increase in IOP, the graft is a little edematous. But in these cases, you can't wait till all the sutures are removed. You'll have to do an early cataract surgery because it's going in for a phacomorphic glaucoma, and the patient will develop a 360-degree PAS. So from being a painless blind eye, we'll convert it to a painful blind eye. So it's important that we intervene early and do the cataract surgery. And quite surprisingly, in this patient, after the cataract surgery, the edema settled down, and I did not have to do a regraft in this patient as I expected before the surgery. So very often it's important to do a staged procedure, because the cornea has a remarkable recovery, and when these coexistent comorbidities are addressed, you can have a residual cornea which gives an excellent quality of vision without compromising the graft. Thank you so much for your kind attention. Thank you.
Thank you very much, Shreyas. As we are slightly running short on time, we can see if later we can have the questions. Over to Kumar, please.
So this is the first case where you can put hooks in a different fashion. You can see that I made it like a diamond form, and then go ahead and make your incision and then do phacoemulsification the way you want. So there are various ways of putting hooks, and you can do a safe phaco. There's another tough case here. You can see there's an adherent glaucoma. You can't use a ring here because the ring, expands only 6.5. So here I still went below the adherent glaucoma, put the viscoelastic, separated the adhesions, cut off the adhesions with the adherent glaucoma. But there the iris would become floppy. Then the best thing there would be again to use hooks. But in such a scenario, you may need to use more hooks. So here you can see that actually I've gone ahead, made my hook separation, and in fact I have put 5 hooks instead of 4, and operating below the adherent glaucoma because I had separated the adhesions. So here the hooks really work very, very well, and you can still go ahead and do safe phacoemulsification. There can be a scenario where you may need to use partial hooks. Now this is hidden below the superior lid. So you really don't need to repair the iridodialysis, which was traumatic. You want to, you can do it. If you don't want to, it doesn't matter. So here I again put 2 hooks so that the iris from there goes away, and then went ahead and did safe phacoemulsification. And thinking that there might be a little bit of zonular dialysis there, I went ahead and put an endocapsular ring to support that area so that it is easily supported, and additional support is given in that area. So you don't need to use 4 hooks always. You can also use 2 hooks the way you want. Now this is a case of subluxation, and I've done a femtorexis, but there is no dialysis. But you can see the area of subluxation is about 3 o'clock position. In such a case, you don't need to use iris hooks obviously because it's well dilated. But here I'm using capsular hooks. So you can see that the rexis was easily picked up. I have done fragmentation of the lens even in the area of subluxation. Go ahead and put your capsular hooks. Once the capsular hooks are placed, sometimes the capsular hooks do come out. If they do come out, don't worry, the rest of the bag is quite strong. You can again inflate the bag and then go ahead and give the support. But when you want to put an endocapsular ring, remember, now this is a mistake. Never start putting the endocapsular ring in the area of subluxation. Always start putting the endocapsular ring. Ideal would be opposite to the area of subluxation. So here I've started putting the endocapsular ring. You have to loosen the capsular hooks a little bit and then put the endocapsular ring. Sometimes they may get entrapped and it may cause an additional problem. But because of experience, I went away with it and went ahead and put the endocapsular ring. Now the eyelets of the endocapsular ring will come in the area of subluxation. So you are not having adequate support there. Then what you can do is go ahead, put in the endocapsular ring, and now you will see that with a Sinskey hook, I'm going ahead and entrapping the eyelet of the endocapsular ring and dialing it so that the area of subluxation gets complete support and that is looked after. So this is one more step you may need to do if you go into an area. Now coming to a Malugan ring, okay. There are various ways of putting the Malugan ring, quite used to it. So one is you get one loop inside, and now I can do the second loop and the third loop and the fourth loop in one shot. So here you are seeing that I'm going ahead, putting in the nasal side. Once you entrap the nasal side, you go ahead and put the temporal side and then the subincisional loop. There are 4, you have different sizes. Now the Malugan ring also goes in through a smaller incision, and here you're putting a Sinskey hook and then go ahead and do your phaco, bimanual IA or IA, and then put in an IOL. As far as the removal of the Malugan ring is concerned, you really don't need to release all of them. What I nowadays do is release only the subincisional one. Even if the rest of them, the iris is held on to it, it really doesn't matter. Go ahead and put in the, just retract the plunger, and the whole Malugan ring will get into the plunger itself. So you can see how smoothly it can just go in. A different case scenario, here you are seeing that I'm going ahead, again entrap the inferior iris first into the loop, now the nasal and then the temporal. Now the ideal instrument is not to use a Sinskey hook, not to use a T, but to use a Krugner's hook. Krugner's hook may be available in the trade. Try to get that, and that works beautiful to go through the side port. Now you can see that I'm doing it with 2 instruments here, and that can happen that when you do it with a Sinskey hook, it can really slip. So don't try to do this. Ideal method is to go through the side port and then engage this strip. So you can see that it just went and slipped behind the iris. In such a scenario, you may have to use a Y, and then again bring it in the front, anterior to the iris, and then entrap the iris. So the retraction method is exactly the same. Here you can see that I have just removed one loop from the subincisional area. I have not disengaged the others. Then just retract the plunger and the whole Malugan ring comes into the plunger itself. So there is different ways of using the Malugan ring or the hook. This is a very shallow anterior chamber. You can see an iridectomy done there. I have already engaged the inferior iris. Now is the nasal again and the temporal, and then go ahead and just release it. So at one shot, you can actually entrap all the 4 loops of the Malugan ring onto the iris. Then comes the subincisional area. Here again the same trick. What I would like to do is use a side port. Make sure that this area goes in, and then use either a Krugner's hook. Here you can see I'm using 2 Bassett's Y and then trying to engage. As I said, this is a very shallow anterior chamber and a very small pupil. The safest method would be to use a Krugner's hook through the side port or a Bassett's Y, which I'm using here so that it doesn't slip at all. Thank you.
Thank you very much, Dr. Kumar. We have a couple of minutes more. He's shown obviously difficult cases of small pupil and using the hooks. Any questions, any clarifications anybody wishes to ask? So we have tried to show you all the different modalities that we have, tough cases, various situations that we have, and how to get over with them. And I wish to thank all of you for joining in for this course, and all my co-instructors for giving in their valuable presentations. Thank you very much.